This is a recreation of a presentation given at the 22nd Annual International Military and Civilian Combat Stress Conference in May of this year in San Diego, California. My name is Guy Lemunion. I'm a Lieutenant Colonel, retired, Army Psych Mental Health Nurse, and I'm a retired VA mental health nurse. I'm currently a clinical psych and research instructor at Northern Arizona University. This is a photo taken of me not long after my retirement in 2010. I started this workshop by photos of images of memorials to combat medics. On the right is the memorial to Army combat medics at Fort Sam Houston, Texas. And on the left is a memorial to Navy corpsmen at Camp Pendleton, California. My qualifications to give this talk include service as a combat medic, 101st Airborne Division in Vietnam. The top left photo is of me in the jungle in Vietnam. The lower right is me on a combined mission with the 5th Mech somewhere near Quezon. And in the middle is me preparing for duty on Battalion Reaction Force. The top left photo on this page is me suturing a soldier in the jungle, saved the dust off. In the middle are my awards from my service in Vietnam, and the lower right photo you've already seen. I started this presentation with some quotations. The first one is from Colonel David Hackworth. Colonel David Hackworth is the most decorated soldier of the Vietnam War. He is the Audie Murphy of the Vietnam era. His awards include 2 Distinguished Service Cross, 10 Silver Stars, 4 Legion of Merit Awards, 8 Bronze Star Medals, 8 Purple Hearts, and 34 Air Medals. 25 combat air assaults were required to earn 1 Air Medal, so you can do the math. Colonel Hackworth says, "There is no job in the insanity of close combat that requires more bravery, steadfastness, and coolness under fire than that of a combat medics. Medics go into the very center of the hellstorm of battle, where the grunt has fallen, where the enemy waits to strike again, and perform major and minor miracles. Almost always a prime enemy target, they do their thing with seemingly total disregard for themselves. Find the wounded, stop the bleeding, patch the wound, administer morphine and good cheer, and then drag and pack shattered bodies of the men they love as brothers back to the safety of a paddy wall or a fold in the ground that provides a little protection from direct fire weapons. No man in the profession of arms deserves more honor and respect than the soldier who wears the coveted combat medic badge. They are true studs who are honored, cherished, and loved by the fighting men they care for." The second is a poem by combat medic from the Vietnam era. He says, "You tried to save your buddies as best you could. You did your best with what you had and cursed the heavens when it wasn't enough. Because in your arms they died anyway. They cried and sighed at the loss of a friend, but you had to move on in Vietnam. The next guy was lucky, or so you thought. You patched him up and sent him off, but sometimes never knew if he really made it. A buddy saved, but lost all the same in Vietnam. A lot of men died, but you survived, or so they said when you came back. But you'll never forget the ones you lost or left behind. They are there upon the wall, their bodies long buried, but their souls still roam in Vietnam. In your heart you still mourn. Your heart still aches for those long-lost friends. But you suffer still from a greater loss, for you now search for the part of you that also died in Vietnam." And the last quotation is from a book by Ben Sherman, who was a conscientious objector in the Vietnam War. He says, and this is a quotation from his final training before he left for the war. This is by the staff. "You learned all we can teach you, men. You've done well. We've all done well. But listen to me one more time. Restore breathing. Stop bleeding. Make mobile. You will do that well. I believe you. And you will do everything you learned here. Every technique, every field drill, every maneuver. You will do everything absolutely correct, and you will do all these things with tears in your eyes and your stomach in your throat. So there's been some recent theory development and research. First is by Lieutenant Colonel Dave Grossman, who wrote the books On Killing and On Combat, talking about the psychology of killing. Second is by Navy Captain Chuck Nash, who's initiated the theory of moral injury, and a traumatologist, Charles Figley, who has also talked about medic issues. He's a major researcher and traumatologist, and most recently by Paula Chapman, who's developed some new research about combat medics. Both Figley and Chapman are former medics. So I started a group called Combat Docs in 2007 at VA Long Beach as a part of the PTSD program. And I was assisted by Dr. Susan Houston, director of that program. We developed this group at the request of a Vietnam combat medic, and it's still in operation and has transitioned to a peer support group. When we started this group, the initial criteria was that they should already have completed a basic PTSD program. They should be referred by clinical staff. And the group was restricted to actual combat medics and corpsmen of any war or from any conflict. What methods did we use? Initially, we had a stakeholder meeting. I'm going to talk more about that. We used a group discussion format, which is heavily researched and shown to be effective, and videos to stimulate discussion, and some military training materials to cause recall, and weekly meeting with the psychologist as a co-therapist. In the stakeholder meeting, that was the first group, we asked the participants who had been referred by clinicians why they came. And this is what they said. They wanted to be accepted by their peers, and they wanted attention for the unique issue of combat medical personnel. They wanted to receive feedback from their peers, and they wanted to achieve peace of mind. They wanted assistance with symptom management, dealing with memories, emotional numbing, and help with self-esteem. They also wanted improvement in family issues, anger issues, the feeling of not being welcomed home, and guilt. They also said they needed to learn adjustment to civilian life, to increase their strength under pressure, and help with medication issues. So next I want to discuss some case studies from some of the participants in the group. The first group member and the one who made the request is a combat medic, also 101st Airborne Division in Vietnam, and after the war worked as an LVN, including work in mental health, and took college mental health training. He had hidden post-traumatic stress disorder. He came to the VA for a medical condition and was diagnosed with PTSD, and soon ended up with 100% service-connected disability payments, and is the author of an autobiographical work about his combat experience as a medic in Vietnam. One change happened rather quickly. A non-combat medic came and said, I want to join this group because I think I have some problems. I'm not a combat medic, but I worked in the amputee ward, and every night these guys that had had their limbs amputated cried themselves to sleep at night, and I can still remember them, and that's bothering me. Now, this is secondary traumatization. We know that secondary traumatization exists, so of course we admitted him. The next, and a very interesting case, was a World War II medic, and he'd served in combat in World War II. After the war, he'd used his GI Bill to go to medical school, and was a successful physician, and had no PTSD symptoms until the time of his retirement, which occurred about the time when former soldiers and comrades started to connect with him via the internet, and he felt re-traumatized and entered this group. The next case study I want to discuss is a Korean War vet. If you'll recall, the initial criteria said that they should have had primary PTSD treatment. However, this veteran was very distrustful and suspicious, and was actually brought by another group member with hopes that he could bond a little bit and then maybe begin PTSD treatment. He was probably clinically depressed, and he did not remain in the group too long. Gulf War veterans did very well in this group. Clinically, they were very similar to the Vietnam veterans, despite having less combat exposure. They had strong verbal skills and easily identified with the Vietnam veterans. The younger soldiers and corpsmen from the War on Terror, OIF, OEF, were not very verbal in the group and did not identify very much with the other veterans, did not remain too long in the group, and I suspect that they had transference issues. Vietnam vets and Gulf War vets are about the age of their fathers. During the period of time that I facilitated the group, that's 2007 to 2009, there were no nurses that attended the group, and I'm told that after that there have been nurses that have attended, but I'm reminded of one that actually attended the Combat Stress Conference regularly, and at her retirement also was said to have symptoms return, including olfactory memory. I can smell what it was like in the emergency room. So I was able to collect some data from this group recently, this year. And what we used was the PTSD scale, PCL-5, the most current version, a post-traumatic growth tool, PTGI, and a moral injury scale, MEIS. I also created a goals survey, remembering back to the initial goals that people gave for coming to the group. I was able to collect 8 surveys, and the group size runs 8 to 12, so I feel this was a pretty good response. The first thing I'd like to discuss is the PTSD scale. PTSD scores, despite several years in this group for many, the top scale is the results of the individual surveys, and the bottom scale is over time from 1 to 7 years. So you can see these results remain high, but possibly dipping down by year 6 and 7. The next is post-traumatic growth scale, and this is variable, ups and downs, no correlation with years, and I suspect this just has to do with the individual response. There's no trend. The last is a moral injury scale. All these are very elevated, indicating a lot of moral injury in the participants of this group. The last of the surveys I'd like to discuss is the survey having to do with why the people wanted to be in the group. Now, this was on a scale of +2 for the highest score to -2, the lowest score. The top-rated item that people reported was the unique issues of combat medical personnel. They said their needs were being met there, and that they felt that they were being accepted by the peers, and receiving feedback from peers was also important. And resolution of guilt was rather strong. And in a reducing order, they felt that the group did help them somewhat with adjustment issues, strength under pressure, or what we would call mindfulness, or their ability to cope with stress. Anger issues were reduced, and feelings of welcome home were improved. Some help, but not a lot, with emotional numbing or shutdown. Of course, many of those are PTSD symptoms, which we've seen were not dramatically improved. They felt somewhat more peace of mind, and very little assistance in self-esteem or family issues. Interestingly enough, the most negative item was medication issues. They didn't feel the group helped them at all with medications. Now, during the time that I did this group, I felt quite a bit of what at that time we were calling survivor guilt, and what is now being referred to as moral injury coming from the participants. And this shows a diagram with symptoms of PTSD on the left and moral injury on the right, and shared symptoms in the middle. The unique symptoms of moral injury are sorrow, grief, regret, shame, and alienation. In the literature thus far, moral injury for the infantry soldiers is related to killing. That doesn't fit for combat medical personnel. Combat medical personnel's injuries are the inability to save comrades and exposure to horrific injuries. Combat medical personnel differ from civilian medical personnel in that they're very well acquainted and even feeling like these are family members that they end up treating for traumatic amputation, loss of limb, death, and other severe injuries. So by update, as of this time, 2015, the Combat Docs group has transitioned to a peer support group, peer-led, meets weekly, uses a peer support concept called Open Mic, has an average of 8 to 12 participants. If I were starting another group again, I wouldn't call it Combat Docs because of some of the things you've heard already. I would call it Combat Medical Personnel. What are the lessons learned? What have I learned so far by starting this group and doing some measuring and returning in contact with this group? I would use a more inclusive criteria. Completion of a basic PTSD program is desirable but not required, because there may be those people, as I explained before, about the Korean War vet who may use a group like this as the back door to get needed help. We've seen that the group is not particularly effective for reduction of PTSD symptoms, improvement in post-traumatic growth, or moral injury. However, it is effective to assist with the unique combat medical personnel issues of combat medics and corpsmen. A separate group may be necessary for OIF. Separate group may also be necessary just for combat medical personnel if a group size grows large. And a model emerging where a therapy group, short-term, and a resulting referral to a peer-led group for the long-term may also be effective. Future planning, this is what I'm going to be doing in the future, is to develop a combat medical personnel website, catalog research and treatment information, because there's no centralized repository for this as yet. I'm also submitting this presentation for AMSIS 2015 in December. That'll be in San Antonio, and for a DoD virtual workshop. I'm also going to prepare a publication and submit for AMSIS publication, and with a VA partner, submit this as a VA practice to duplicate the development of these groups. Here's my contact information. If you can spell my name, you can find me on Facebook. I'm contactable through the Combat Stress Conference website, and I've included my work email for as long as I'm working at NAU. This presentation ended with a questions and answers session, which included interviews with group participants, and you'll see those after this slideshow. Thank you for listening, and if you feel led to develop such a group, please contact me. I'd love to help you. Thanks for listening. Bye-bye. Go ahead.
I came to the medics group about in 2008, so that's about 7 years ago. And the reason being is that when, as a Vietnam veteran, most of us, when we got out of the military, we just were given a pass and we left, and that was it. And I wanted nothing to do with the military. I was wounded, and I had hearing loss already, and so about in 7 years, 10 years ago, my world started unraveling, and all the symptoms of PTSD, the fear, the trauma, the anxiety, it all started coming back. And at that point, well, okay, I know where this is coming from. So that's when I first approached the VA. But when I got to the VA, and the interviewer, and as I went through the process, then they said, okay, you're a combat medic, Purple Heart. They sent me directly over to this group, and I have been here ever since. I can tell you that the benefits have been, I mean, you can't, clinically, put them down on paper, but the group, the format of the group, where we're all together, we're all on equal footing. We know each other. We understand what we've all gone through, and that in itself is what kind of nurtures an openness and a desire to come out and discuss your issues. I've been here with a group where we had veterans from World War II, the Korean War, on down to the current Iraq, Afghanistan issues, and we're all brothers of the same issues and traumas that we've all experienced. Granted, okay, we're all on medication, we're all on doing different things for ourselves, but the camaraderie and the brotherhood that this group has created, it's an intangible. It's you can view it as a medication, so to speak. You come here for your dose every week, and I'm saying things that the younger vets are also saying. This is why we come here.
And how can it be improved? How can we do this better?
That's a good question, and I'm not a clinician. I can say to you that having, at this moment, we don't have any professionals to kind of guide with us, but having a professional might be a way to improve, so that somebody who is clinically trained can enhance the dialogues and give us perspectives and allow tools and techniques that we can work with to continue. I am aware at my 60 years of age that this is a lifelong struggle. I have learned to deal with it and for a quality of life. And if anything, at this stage in my life, it's not just so much for me anymore, but the younger brothers that are coming behind me. They're the ones that need to be attended to, and this is a program that has helped me, and obviously I'm sure it will help many others.
My name is Peter F. Martinez. I was a combat medic in Vietnam, 1968 through 1970. I did 2 tours, one with the 196 Light Infantry Brigade. The second tour was with the 91st Evac Hospital. I waited 40 years before I asked for assistance from the VA, and mine is a little selfishness. I asked for help from the VA so that my wife would not have to go through the trials and tribulations of being married to a combat person and not understanding why I did the things that I did. So mine is so that my wife did not have to go through these. When I came here, I was diagnosed with PTSD. Also been Agent Orange, which gives you a lot of other affiliations to diseases, diabetes, and other things that you get being in Vietnam. Coming to the Combat Medics group, I was referred to by my psychiatrist. I came here, I listened for a year without saying anything, and then I progressively started to engage myself with the class. Recently, I have become a leader in the class, where I am a facilitator for the peer-to-peer, and so I lead the group. How do I feel that the group should be able to progress? I feel through education is the best way for them to progress. Education in taking more classes here at the VA to enhance their ability to deal with PTSD and other symptoms that they may or may not have. That's pretty much about it.